So I will just read out for you because this pointer is not working. So you can see the MP joint on the dorsal aspect. There is a central tendon, and when we go distally towards the PIP joint, you consider me like this is the head is a central tendon, and my arms are the lateral bands. So you just whenever you do repair, we every time have a mnemonic among to think what are the extensor tendons, how they are extending and dividing. So how I used to think, just I am sharing you. So central head is a central tendon. My head is a central tendon which is going to insert on the middle phalanx base, and my two arms are the lateral bands. So the confusion lies every time we are saying lateral band, and to the common tendon of the interosseous and umbilicus also we are saying lateral band. So you consider central tendon my head, and these are two lateral structures, radial side and the ulnar side. Now my central, this head also is taking the connections from the lumbricals and interosseous, and these two arms are also taking the connections from the lumbrical and interosseous. So my head taking some support from the interosseous and lumbricals, insert onto the middle phalanx base. These two arms on either side take connections from the lumbricals and interosseous and goes dorsal to the PIP joint and insert into the distal phalanx base. Now why these structures we need to know that these connections, because whenever these structures are unrepaired, then the other joint next to if we are repairing the MP joint, then PIP joint will not work if it is not repaired, and if we are repaired the PIP joint on the center, then the PIP joint will be a problem. Okay. Already we have the slides by the Bhaskar Anand sir and Girish Gupta sir. There are many techniques. Usually we come out with this modified Bunnell or modified Kessler, and in thin flat tendons we do the running epitendinous sutures, and then to super that we do a cross-stitch mattress sutures. We all know that zone 1 is a mallet finger. This present everyone knows like a drop finger. It can be a bony mallet or an extensor tendon rupture. What is the name of this extensor tendon? Terminal tendon. Okay, this is not a central tendon. And usually we splint them like this, which is extending the PIP joint and the PIP joint, which is not good. Why it is so? Theoretically, if we have to push this kind of splint, it should be in a PIP joint flexion. But experimentally, it's seen that irrespective of the PIP joint, there is no role of means extending the splint in the PIP joint. Why? Because tendon gap doesn't get closed or open up with the movement of the PIP joint. So better not to fix that, because it creates a lot of pressure and difficult to keep it for 6 weeks. So how to splint this TIP joint? Just on the dorsal or the volar aspect, and then it should be for 6 weeks, but you can take it off every 3 or 4 days, keeping the joint in the same, clean it and then put it back, and then gradual weaning after 6 weeks for 4 weeks. If there is a bony mallet fracture, usually we do an indirect fixation because the fragments is very small. So the series of pictures are there. You can see the first picture, the K wire is just proximal to the fragment. Then we align this K wire in the the shaft of the middle phalanx. Then we extend it to have a good fixation of this wire, so it doesn't get move when we extend the DIP joint. And after extending the DIP joint, we get a good approximation of the mallet fragment, and to keep it and maintain that, we do an axial fixation. And once all it is done, we have to check the movement. You can see it is a means national player, basketball player, and 2 fingers are having a mallet bony fragment, which is nice. Sometimes we come across with a minor cut.